Hello and welcome to this screencast presentation for the Healthy Places module. This week I'm talking to you about the socio-spatial determinants of health. In this presentation I'm going to be giving a brief introduction to the focus on socio-spatial determinants of health, and then a quick summary of those determinants, and then moving on to a discussion about the challenges that these face for planning as a profession. So first of all, I just want to set the scene a little bit, following on from last week's focus on the historic relationship between spatial planning and public health. I think it's important to recognise that there's quite a lot of continuity in terms of the role of planning in managing and improving public health. And that really applies to this issue of the social gradient. So the image on the right hand of your screen is of a a slum in the north of England. This is actually taken around the 1950s, and the image on the left, the figure on the left, is the map showing the different, pardon me, life expectancies of men in Sheffield between the years 2013 and 17. What we're looking at really here is the impact of poverty on health. And the social gradient, which is referred to in the key reading for this week's session, is really focusing on the fact that the relationship between income and health is pretty stark and has always been pretty stark. So when we're looking at health inequalities, we're looking at income inequalities, and we're looking at the impact of poverty. And Sheffield, you could look at more or less every map of the city that looks at demographic data, and a similar pattern will emerge. You have very affluent areas which experience better health outcomes, and you have areas where people experience far worse health outcomes, and also those areas will be areas of multiple deprivation, high levels of unemployment, low levels of education, etc., etc. So there's an awful lot that hasn't changed. So the job has always been that you have areas of cities in particular, and the country in general, where the population experiences worse health outcomes than other areas. And we can try lots and lots of different interventions, but ultimately what we're looking at is the impact of different levels of poverty and income. And so what changes over time is really the interventions and measures that that we try to sort of put in place to balance this out. And a lot of the time that has been influenced by the kind of ideological view of equality and inequality that sits within our governance structures. That's not something we're going to focus on in this presentation, although it will form the basis of the discussion in class. But this is really that we can't talk about the relationship between health and place without talking about the relationship between health and poverty. So here's a brief summary diagram of what we're talking about when we talk about social determinants of health. So this is not the same as socio-spatial. We can look at the spatial factor in a moment, but when we talk about social determinants of health, these will probably be familiar to you if you remember from the module last year, where we looked at this broadly in terms of ideological approaches to planning. But the kinds of things that have a huge impact on health are things like economic stability, so types of employment that you have, your income levels, levels of debt that you're managing, neighbourhood and physical environment, housing quality, transportation safety perceptions of the area, crime rates, quality of the green spaces, etc., walkability, education levels, levels of literacy, levels of native language spoken, levels of early childhood education, and the level of education that people attain in a particular area. Food, so whether or not people have adequate food in terms of levels of hunger, but also whether people have access to nutritious options and a healthy food environment. Increasingly, we're recognising the importance of community social connection in terms of health as well. So There's a direct correlation, obviously, between poor mental health and poor physical health. They are all the same thing when we're talking about health. We're not differentiating there. So social integration is important for health. Being part of a wider support system, having a community that you can feel part of and engage within, and not to feel discriminated within your community and social context. And finally, the healthcare system, which is not to be dismissed as only an add-on to this, but obviously this is all about health, good health, encouraging good health rather than treating ill health. So a healthcare system is an important part of the puzzle, but really we want to reduce the amount of healthcare that people need to access by improving their quality of life. So all of these things are there's a very strong evidence base for this. This is no longer contentious. This is not something that we're suggesting may be a contributing factor to health. The empirical work and the evidence base for all of this is pretty comprehensive now. So now the challenge for the profession of planning and for all of the kind of allied professions that work with public health is to actually think about how to address the issues that sit within these different categories. So if we know that housing contributes to poor health and that good quality housing can improve people's health outcomes, then how do we actually address that? What are the mechanisms for doing that? Are those mechanisms currently available, or do we need new policies and new structures to be able to deliver better housing, for example? So bringing in the term spatial to the discussion now. Spatial can apply to both the spatial distribution of health inequalities, which is what we're looking at in the diagram here on the left, which I'll talk about in a moment. Or it can be in reference to the spatial drivers and responses. In other words, if we look at the diagram of the image, on screen here, this is one example of the unequal health distribution within the city of Sheffield. And what's nice about this is it's chosen a single bus route. So the bus routes in Sheffield tend to pass through the city centre, and they connect usually an area of low multiple deprivation with an area of high multiple deprivation. That tends to be the pattern of the transport within the city. So this was the 83 bus route, and it connects one of the most affluent areas with one of the most, passes through one of the most deprived areas of the city. And this shows the different life expectancies of people on the same bus route within a very short geographical area. So this is one way of talking about health and space and place, is to look at it in terms of the unequal distribution of health outcomes. And the other way that we talk about health and place is in the kind of design spatialized interventions and responses to some of those issues. So thinking back to the previous slide where we had all those social determinants of health, some of them feel more naturally spatialized. So things like the location of housing, the location of public green spaces, the transport infrastructures and those kind of things. So there are certain interventions around health and place that feel more naturally spatial. But when we're talking about spatial health inequalities, it's also about this sort of using it as a visualized distribution of different health outcomes. I think it's important to recognise that an awful lot of the literature around planning and health tends to focus upon design interventions. So a lot of the literature will be around neighbourhood design, how we can design better places for better health, how we can improve things like walkability, how we can improve the design and access to green space, how we can improve transport infrastructure, and those kinds of things. So things around neighbourhood design, transport, things that align quite nicely traditionally with the remit of planning. I think it's important to recognise that design responses, things like neighbourhood design, clearly have an important role to play. But where I think it's worth sort of giving a word of caution is that if you interrogate some of those, the literature and the best practice guides and the policy directives around spatial responses, design-based responses, some of those are really about changing space in order to encourage behavioural change within the people that live in those areas. and some of them therefore don't tend to address some of those deeper levels of inequality. So use, for example, things like the quality of green space in the area. Um, so you could look at all the empirical evidence, for example, that improving quality and access to green space improves health outcomes. So you could put all of your efforts into creating a really nice quality green space. The expectation there is that the people in that area would then have a good quality space that they could access and get the benefits of. However, a lot of the barriers to good health within areas of multiple deprivation are not just spatial. So you might have an absolutely fantastic park on your doorstep, but if you work shift work, then it's not as accessible to you because you tend to be working during the day and can't access the green space because you're at home during the night time, or you have complex caring responsibilities, or you have complex mobility, or you suffer from complex mental health problems because of high levels of economic instability and precarity in your life. So there are lots of complicated reasons why and intersecting reasons why you have health inequalities in an area. And I think that responses that think that if you just create a nice environment, then people will be able to improve their health, don't really address some of those deeper structural inequalities. So if we're going to take a more meaningful approach to this, then we have to acknowledge where not to cherry pick too carefully from the available information about the drivers and determinants of health, and to really try to focus on where the significant socio-spatial issues are. And again, this is taken from the key reading for this week's session from the Routledge Handbook of Planning and Health, which gives a really good overview, I think, of a lot of the key issues, which is why I've chosen it for the textbook for the course. So from the chapter that you've been asked to read, these four areas are the ones that have really been focused upon. And I think there's a good case to say that these areas are really the sort of key issues around health inequality. So we have, first of all, housing design and condition. So this is to do with the interior spaces of the home. So before we get into neighbourhood layout and access to amenities and all of those things, we're actually talking about the quality of the buildings within which people live. Are they of adequate size so that people aren't living in overcrowded conditions? Is the building well maintained? Are people able to keep warm and keep cool? Is the building damp? Is it dangerous? Is it well maintained and or is it actually contributing in lots of different ways to poor health? So I think it's very important to note that it is around housing condition is one of the most important drivers. And so if we focus all of our attention on creating beautifully designed neighbourhoods, but we don't think about who's building the houses for the most vulnerable and who's addressing those inequalities of health that are linked to housing quality, then we're kind of dodging the key issue here. Transport and active travel are really key, but again, it's more complex than just, is there a nice sort of cycle network that people can use? But is the pattern of people's everyday life actually compatible with active travel as well? Are they able to participate in active travel? Are they able to commute to work using these methods? Is it feasible for people to engage in active travel in their day-to-day lives because of all of the sort of complex intersections of their lifestyles, the pressures that they're under, and the places that they live? Air pollution. This is one of for me this is one of the most important issues that's kind of emerging into the public consciousness because of the global the COVID pandemic and the relationship between air pollution and poor health. This is an area that there are some areas of affluence that experience poor air pollution, but you tend to get really bad air pollution in sort of highly condensed areas of housing and industry and transport. and those tend to be, correlate with the areas of higher social deprivation still. So the negative impacts of air pollution from traffic, from industry, are really, this is an area that we really need to look at. And again, air pollution is not something that you can expect people to be able to deal with based upon their own individual behaviour changes. There was actually um, a report that was published when there was the different sort of impacts of air pollution around primary schools were highlighted in a report. I think it was focusing on London. There was actually some government guidance to parents about how to avoid the worst impacts of air pollution while taking their children to school and home from school, such as avoiding the most congested traffic routes and that kind of thing. And I remember thinking at the time that if there was anything that was sort of the least appropriate thing to ask people to try and address with their own individual behaviour, it was the response to air pollution. Air pollution is something that needs to be tackled at a structural level. It needs legislative input. It needs, a sort of strategic planning input to look at the drivers of poor air pollution and to tackle those. So I think it's very good that this is now being recognised as one of the key global factors in public health. And food and diet. And food and diet is a really interesting one because there is always an attempt to address this spatially, in that you can look at all sorts of different correlations of data around things like prevalence of fast food takeaways and areas of diet related poor health, and see a strong correlation and assume that the thing that needs tackling is the high level of takeaways. I think that you could, if this is where, sort of interrogating and challenging the underlying structures of research are really important, because if you were to also maybe look at a correlation between high prevalence of takeaways and poor housing condition, you probably find a similar correlation. And so there is an assumption that people have a poor diet because they eat a lot of takeaways, rather than thinking about why people are driven to preferring takeaway food. What is it about the function of a particular area, or the shape of people's lives and the challenges that they're under and their home environment, that means that it's better for them to go and get takeaway and into the home? Because of course, what's not, there's no way of measuring where the people who use those takeaways actually live. So now that we have lots of kind of deliveries and lots of different apps that people can order food from lots of different parts of the city and have it delivered, a high prevalence of takeaways is probably as much to do with things like land cost and where a small independent can afford to set up, as it is to do with where their customer base is. So I think we need to start thinking, interrogating the issue around food and diet in a more complex way. It isn't just that people can't access good food or can't afford good food, although those things are important. It's also to do with the drivers of different kinds of food consumption and how that links to other socioeconomic factors like mental health, depression, anxiety, the pressures of feeding a large family, the pressures of feeding people when you have complex working patterns, the role of food in comfort and cultural importance, all those sorts of things. So food and diet is a really key driver of health, but it is much more complicated than just what food is available in a particular area. So then for me, the real challenge for planning is to step outside of the areas, the low-hanging fruit, as I would call it, really. So there are things that there's clear evidence that having things like, certain design interventions are important in addressing health inequalities. However, if we're not careful about addressing and tackling the root causes of those health inequalities, then what we'll do is we will just keep on creating more and more facilities for people that are already enjoying quite good health outcomes, thanks very much, and they will likely access those. So if you think about who tends to access the existing high quality green spaces, and as soon as there's a new offer of that kind of thing, then it will be attractive to people who are already familiar with engaging with nature, who have the time and the resources to do that. And that this is a quote from another chapter within the course handbook, which is looking at public health interventions in Portland, Oregon. And I'll read it out. Despite the undoubted accomplishments, many of the actions and approaches summarised here have tended to favour the well-educated well-off who are already likely to access healthcare and maintain healthy lifestyles. A cynical interpretation would suggest that health is used as a feel-good add-on when it's convenient for these officials to use it as a rallying cry. So this is a word of caution really for you as emerging professionals in this area, to step outside of those traditional areas where planning has intervened in public health. In other words, creating nice places and applying best practice around things like transport and neighbourhood design and access to green space. These are things we know, and we know that they work, but we also know that just addressing those design elements and those spatial elements are not going to be enough to tackle the underlying root causes of health inequality. That's going to take a new approach. And by a new approach, this is a word I'm going to struggle to say, interjurisdictional approaches, I think is the way forward. And this is something that's, again, is recognised in the literature, which is that there are different jurisdictions around these kinds of issues around things like education, healthcare provision, food provision, infrastructure provision, and design and planning. So there are all sorts of different people that are involved in professions that are involved in things that could improve health inequalities. But what we know from the existing empirical base and the evidence base is that what we really need to look at here is providing good quality housing. That's not just making good quality housing available for someone to buy. That is looking at where people who are experiencing the worst health outcomes are living and thinking about how we improve their housing. So it's not just about build nice housing and everything will be fine. This is about looking at things like retrofitting, replacing outdated housing stock, dealing with poor housing conditions that perpetuate. We also need to look at things like jobs that don't make people ill. We know that precarious work, so we used to think about jobs that make people ill in terms of things like heavy industry, coal mining, working in toxic environments, dangerous environments. Increasingly, jobs that make people ill in different ways. So it could be things to do with just the chronic stress, which I've mentioned here as well. So 0 hours contracts, not knowing how much work you're going to have in the coming week or month, not knowing whether your contract will be renewed, not really having any job security, having to work several different jobs in order to be able to cover the rent. And then on top of that, there are the working environments, which still, people working in very poor quality factory environments. We know that during the COVID pandemic, there's been lots of reports of unsafe working conditions. Unsafe working conditions continue in this country, and obviously it's a serious issue globally as well. We need air that doesn't make people ill, and that is not something that we can put back onto individuals and just design out in small spaces. We need to tackle that one at a much bigger scale, and we need to have the take an approach that actually looks at guaranteeing a particular level of air quality for everybody. We need food that doesn't make people ill, and I think that's an important distinction, because at the moment we talk about food choices and making sure there's a healthy availability of food, but actually food is making a lot of people ill. And so there's actually something to do with the quality of the food that's available, rather than just that people are making bad choices. We allow a food environment to exist which is borderline toxic in some areas, and that food is perfectly legal and cheap and palatable. So I think that's something that we need to think about. Again, one of the biggest drivers of health inequality is chronic stress. So we know that chronic stress of living in financial precarity. We also know about the chronic stress of living living as a victim of discrimination. So that can apply to people from different ethnic groups. It can apply to people with different levels of physical ability, mental health, cognitive impairment, and that kind of thing. So chronic stress of living a precarious and stressful life is one of the biggest drivers of health. So we need to look structurally at what's causing that and how to address it. And kind of finally, really, living in a nice place with a good quality green space and good access to services. That's the cherry on the top, but it's not actually going to be the thing that makes the biggest difference. So we should be looking at those things, but we should not be looking at those things and ignoring all the more difficult work that needs to be done. So I hope this has been useful and interesting, and we'll pick up some of these discussions in class, and good luck with the reading for this week. Here are the references on the final slide, and I look forward to seeing you in class.